So, are we ready to start?
Yes, please.
So, dear colleagues and friends throughout the world, welcome everyone to this FIP digital event, Reducing Medication Harm Through Medicines Use Review, Pharmacists at the Frontline. It is my pleasure to welcome you all, and it's great that we have this kind of virtual tools to get together even at times like we have today. And it's a pleasure to announce that it seems that there's almost 600 people who are participated and actually registered to participate to this event today. And it shows that we are dealing with a very important topic where pharmacists really are at the front line. And it is great that our world organization, FIP, has taken the lead to make it possible for pharmacists to be involved in promoting patient safety, and particularly medication safety. That is a special area for us as pharmacists. So maybe it's time to turn to the next slide, please. And today I will be your moderator. I come from the University of Helsinki. My name is Marja Airaksinen, and I work there as a professor and head of clinical pharmacy group at Helsinki University. And why I am here today is that I had an honor to co-chair the FIP working group on patient safety that started some years ago and finalized its work last August. And I have been also involved and in that position in preparatory meetings by WHO to establish the third patient safety challenge on medication safety that was launched in 2017. And before that, I was also representing FIP in establishing the patient safety curriculum guide, the multi-professional version that was launched in 2011. And in my own home country, I have been very actively involved in national patient medication safety initiatives since 2004. And it was the time when Council of Europe was the first international organization within Europe that started to establish recommendations for its member countries on patient and medication safety. And I can say that international work has changed a lot in our country, and also the cooperation that we have nationally and locally and within professions in patient medication safety. And I hope that this patient safety will become the same kind of issue for all of you. And so the picture of me, so I wanted to make this kind of picture here to show this is the part of our team at the University of Helsinki. And we work closely with our universities, the community pharmacies. So we have a lot of projects ongoing that is related to practice development. And finally, there's the picture of Swiss cheese. And I hope that everyone of you have seen this and also what it means, and hope after this session and these 2 hours with our esteemed colleagues presenting, this will be something even more special for you and something that you can start using in your daily practice. And I'm sure that you will find out what is Swiss cheese in this context of patient safety. May I have the next slide? And there's some couple of announcements. This webinar is being recorded and live streamed via Facebook. The recording will be available on the FIP website. You may ask questions using the question box provided. You are welcome to provide feedback to FIP concerning this webinar. And we also encourage you to become a member of FIP, and you can find links how you can approach FIP in these matters. And then it's time to go to our program today. So after this introduction, you will have an opportunity to listen to these 3 esteemed presentations that are related to medicines use review. And the first one is in the community pharmacy setting, and then the second one in a hospital pharmacy setting. And then you will also hear about the new recently launched FIP toolkit on medicines use review. And I hope that this will be inspiration for you to get started, or if you already have gotten started, so that progress with your practice development towards patient medication safety and harm reduction. And we have also reserved plenty of time for your questions. And please use questions and answers port for that. And our speakers will be available also to respond to you during the session, but also at the end we will pick at least part of the questions, depending how many questions we will have, but try to respond to as many as possible. And then it is time to wrap up and have the final remarks. And then we can go to the learning objectives, so that after this session, you could define what does medicines use review mean, and you could be able to discuss the clinical and economic evidence supporting its implementation, why it is important, why we should be doing it, and why we should shift our practice towards medicines use review. And then also after the session, you should be available, explore examples of medicines use review practices from different regions, and also become familiar with the FIP medicines use review toolkit to support the advocacy and establishment of the service in your own country and your own workplace. And just to remind you that FIP has published these 3 excellent documents to support pharmacists' involvement in medication risk management. And they are in a row of, so that the first one is this patient safety document that is giving you the big picture about patient medication safety and safety culture in healthcare and how pharmacists can contribute to it. And then the second one is about medicines reconciliation. And it is something that we need to integrate with medicines use review, or make sure that the medicines that people are taking are the medicines that are designed to be used. Because the problem in our health systems is that the medicines are not updated, or that and to transfer information with the patient from one care unit to another. So I think that is a global problem that is also recognized by the WHO, and here you can find tools how to manage that problem. And then today the focus is in medicines use review, and there's the toolkit that you will learn today more about. And then it is time to start with our contributors. And the first topic is focusing on medicines use review in community pharmacy setting. And my pleasure is to introduce Dr. Filipa Alves de Costa from Portugal as our speaker for this topic. And Filipa works as assistant professor at the Faculty of Pharmacy, University of Lisbon. And she has several positions in her home country, but also internationally, that are related to clinical pharmacy and pharmacists' role in healthcare. And what to pick from here is her contributions to FIP, then Pharmaceutical Care Network Europe, and the European Society of Clinical Pharmacists. and they are even operating in Europe. They have a lot of contributors and members, also other continents and countries. And what I would be personally interested to hear from Filipa is about this working group on medication review at the European Directorate for Quality of Medicines. And maybe that is something that in the questions and answers part you can tell us more. And then finally about Filipa's work, published work. It is focused on service development, medicines use, medication adherence, pharmaceutical care and health policy. So quite wide range of issues that medicines use review is also in core. So the floor is yours, the virtual floor, Filipa. So we are looking forward to your presentation.
So thank you, Marja. Thank you very much for the kind introduction. And I would just like to add that in terms of FIP, I'm part of the executive committee of the social and administrative pharmacy section. And on their behalf, I pass on our acknowledgements for our involvement in this interesting session. Can I have my first slide, please? So let's start with thinking why we need medicines use review, why we need it. And we know that, in fact, public health improvements are mainly attributed to the so-called determinants of health, including not only access to sanitation, but also improvement of social economic conditions like education. However, medicines are one of the important contributors to the improvements in life expectancy. In fact, they are the most widely used and most efficient health technology, and they have been used for long to improve the life of human beings. However, as stated by Paul Ehrlich, the main function of therapy consists of learning to produce magic bullets that are lethal to the infectious agents, but do not adversely affect the health of the patient. And this means that there is also a risk associated to the use of medicines, and this has been quantified by Hellman. And if we look at the overall benefit of using a medication, we can see that there has been an improvement in about 15 years of life expectancy that are a result of therapeutic effectiveness. But also if we look at the mortality that's caused by adverse drug reactions, there has been a quantified reduction in 19 minutes of life. And so for all these reasons, this has led important international organizations like FIP and WHO, among others, to try and quantify the costs of inappropriate use of medication, and therefore develop strategies and interventions that could potentially lead to improvements in the responsible use of medicines. So if you look at this image on your right-hand side, you see a report that everyone knows for sure that was published in 2013 by the Institute of Medicines in the US, which has shown us the enormous amount of money that's wasted on irresponsible use of medicines, and half of this money results from non-adherence. The next slide, please. How can we improve medication use? There are several interventions that have been studied, and this table is extracted from a Cochrane review that includes 75 systematic reviews. So in fact, it is a review of reviews, and it includes several interventions, but it also includes different target groups and outcome measures. And the main message that we can extract from here is that most interventions are effective, but there are some exceptions. And these are the ones that are purely educational and also the directly observed treatments, except for certain conditions. So there is enough evidence that the pharmacist can have a determinant role in improving medication use, but of course not all interventions will make this will lead to this expected improvement in the responsible use of medicines. Next slide, please. So definitions are extremely important, and those of you that know me better and my background will know that I have been very much influenced by Filipa van Mil, who was a strong defender of definitions. And in fact, he passed more than half of his life trying to show us that if we don't know what we're talking about, we might be confusing terms. So I would like to spend some time with trying to establish the boundaries between medication review and medicines use review. And these two terms are often used interchangeably, where in fact they mean two different things. So medication review has been defined by PCNE in a position paper that was issued in 2016 as a structured evaluation of a patient's medicines with the aim of optimizing medicines use and improving health outcomes. And this will entail detecting drug-related problems and recommending interventions. Now, if you look at the table beneath the definition, you will see that there are different types of medication review, and this depends on the sources of information that the pharmacist can use. So you can have simple medication review where you just have access to the medication history. You can have intermediate medication review where you have at least two sources of information, one being the medication history and the other one being the patient interview or clinical data. And then the third one is when you have three sources of information, so medication review, patient interview, and clinical data. So in fact, medicines use review is one part of medication review. And if you look at the type 2A, it matches that one where you have access to the medication history and to the patient to conduct a patient interview. So next slide, please. So medicines use review service is a service that consists of structured adherence-centered reviews with patients on multiple medicines, particularly those receiving medicines for long-term conditions. Now, this service therefore focuses on medication adherence and is only one part of medication review, as I have mentioned. It may take different terms, adopt different terms depending on the country. So in the UK, they use the term MUR, standing for Medicines Use Review. In Canada, for example, they use the term Meds Check. In Switzerland, polymedication check. And yeah, there will be many others. These are just a few examples. Now, the most important thing to remember in medicines use review is that this service has been evaluated in some of these countries. And in fact, in Switzerland, I have two references here, which I would strongly advise you to check better, but unfortunately, they show you that the service only has an impact on humanistic outcomes and acceptance, but there has been it has been unable to show any significant impact on adherence. And this was in fact the reason why the service lost acceptance by the health insurance and is no longer remunerated. The service is still available and is of course part of the undergraduate and postgraduate education and is still delivered in community pharmacies, but it's currently not being paid. And this is, of course, important for the implementation of the service. Also in Canada, the service has been evaluated and we know that it has shown to decrease DRP, so drug-related problems. However, these are just process measures and cannot be really, do not always transfer into a meaningful patient outcome. In the UK, the service has just been decommissioned this month, unfortunately, and this was after an evaluation that was initially conducted in 2016 by David Wright, and there's a long report about the evaluation of the service. I'll just mention a few of the highlights, and some of them are there was a high variability in the delivery of the service. The other one was that it was perceived very positively both by patients and by pharmacists, but not by GPs because it was perceived to have to result in some duplication of work. hopefully to be overcome by the introduction of summary care records, but in fact this was not verified. This report also highlights that there was some confusion in terms of the focus of MURs, if it was a clinical or an adherence service, and therefore it was recommended that there was more emphasis put on training of pharmacists so that they could understand better what to expect from the delivery of this service. Now, in terms of robust evidence, what this report concludes is that although MURs do result in improved knowledge of the patient about the way to use their medicines, most MURs are delivered as one-off interventions and therefore do not result in an improvement of adherence, or at least have not been able to demonstrate this improvement. Next slide. So this is just a continuation of my former table extracted from PCNE, and this is to support my argument for we should know what to expect from each service we delivered. And in here you see that for each type of medication review type, you can expect to detect or identify different types of problems. So in terms of medication review type 2A, so MUR, equivalent to that, we can expect to identify different forms of non-adherence, of course, not all of them, partial or erratic non-adherence, and eventually also some problems with handling medication. But of course, we cannot expect to identify problems that would need us to have access, for example, to clinical or laboratory data. Next slide. So this is just a highlight of 2 studies we have conducted between Lisbon, Basel, and Ljubljana. And in this study, this was called the practice study. And we have found that there were a wide variability of services offered by countries. You can see on the left-hand side that medicines dispensing is, of course, the service that's more widely available in all countries. But you can also see that there are nearly 50% of countries stating to provide pharmaceutical care. But more important than that is that the other ones which did not mention to provide pharmaceutical care, they did mention some services that are believed to fit into the scope of pharmaceutical care, namely medicines use review and assessment of inhalation technique, and also adherence support. We also found in this study that medication review is consistently provided across Europe. However, the most common type is type 2A, so the one fitting MUR, which was found to be reported by 14 countries. Next slide. But why is it that not all pharmacies globally provide these services? And one of them is, of course, the fact that services are often not remunerated. And when they are remunerated, they rely very much on a fee for service. So this does not incentivize pharmacists to make sure that or become accountable for the delivery of optimal patient outcomes. And another barrier is, of course, motivation. So even when the service is paid, that does not mean that we are able to provide it. And one aspect is the organizational and structural framework in which we operate. So sometimes we try to implement services, but we expect the same workforce to be delivering more and more services without being able to restructure the pharmacy, the community pharmacy, in order to be delivering more services where all pharmacists are available and motivated and appropriately trained to deliver these services. So another problem is competence. So in this aspect, surely FIP has done major work by developing competency frameworks that describe the behavioral competencies across various domains or clusters. And here the one I show you on the screen is just one example that shows you that if you are to provide MUR, you need to be perfectly competent in various domains, which are illustrated in different squares of the image. The final one is, of course, context-specific guidelines. We need them, even if we have international guidelines, we need to be able to have context-specific guidelines which will support pharmacists in understanding how they start and what they need to do exactly and how. So next slide. So coming to that, as Marja mentioned, I've been involved in the Directorate for the Council of Europe, which is in charge of monitoring the application of quality standards for safety medicines and their safe use. And one of the most recent publications of EDQM is the resolution of pharmaceutical care, which was published in March 2020 and is available online. I would advise you to check it. And as a natural consequence of this work that was developed in 2019, a working group for medication review was also created and is currently developing a guideline that can be applicable across member states in different settings, including community pharmacy, hospital pharmacy, but also residential care and eventually GP practices. And here on the right-hand side, you can have a brief snapshot of the structure of this guideline where all the different aspects are highlighted. So of course, the ultimate goal of this resolutions and guidelines are implementation at the national level, but that does not necessarily happen. So in Portugal, coming to my final slide, next slide, please. In Portugal, we have also been working on a recommendation for the implementation of medication review. Initially, this was set up to be applicable only to the community pharmacy setting, but because it was decided that it was relevant for all settings, we have restructured so that it's also applicable to hospital and to residential care. So the main aspect of this guideline is that it has practical tools included, and this is very important when you're in a non-native English speaking country where often you lack the necessary tools, but also it highlights the responsibilities of each member of the pharmacy staff to engage in each of the phases of the medication review. So to conclude, my final slide is that although Everett Koop has mentioned that medicines do not work in those patients that do not take them, that is certainly true, but I would add, in the context of this confusion between MURs and medication review, that medications will work differently in patients that take them erratically. This is why we need MUR, but when patients take medication correctly, but the medication regime is still suboptimal, the desired outcomes are not achieved. And this is why we need not only MURs, but above all, medication review. So thank you for your attention.
Thank you very much, Filipa. May I say that way, Dr. Filipa? And so it was excellent introduction to medicines use review and the principles and the levels we can and comprehensiveness of the reviews, how we can conduct them as part of the healthcare team. And now it is time to move on to the next presentation that will take us to the hospital pharmacy setting. And please, if you have any questions and comments related to Filipa's presentation and the community pharmacy setting, please use the questions and answers port for that. And it's my pleasure to now introduce the next speaker, Ms. Nai Mei, and she comes from China, Taiwan, and she's working as a clinical pharmacy specialist at Shin Kong Wu Hon Su Memorial Hospital, and Mei has a master's degree at the University College London, UK, and she is also very enthusiastic about international affairs and has been accomplished a lot already as a junior, and she is a supervisor and chairman at International Affairs Committee, the Taiwan International Pharmacy Advancement Association, called TIPA. It's almost like we had in Finland this TIPA project some time ago when we wanted to promote these medication reviews and pharmacist role in healthcare. Sounds like very familiar to me, and I'm sure that you will be very successful with this project. And also Mei is a clinical pharmacist who is specialized in critical care and cardiology at the teaching hospital in Taipei, where is it the same as where you are working. And you serve also as a preceptor coordinator for both international and local PharmD students. Very important also to be involved with students, like introducing these new practices and clinical practices to our students. So the floor is yours. You're welcome.
Thank you. Okay. Hello to all those listening in. Thank you for the introduction. I'd like to first thank FIP for organizing this webinar and the support from my director, Mary. I'm always excited to participate and truly thankful for the opportunity to share information with pharmacists from all around the world. I do have quite a few slides, so without further ado, next slide. So hopefully everyone has seen or heard the Swiss cheese model at some point. Here, we're going to apply that concept to why accidents happen, resulting in patient harm. So with system alarms, the process of having someone check or even double checked act as a form of defense, in which this case is kind of illustrated as slices of cheese. When you have staff shortage, inexperienced team members, plus poor team communication, the result of failing to monitor vital signs is bound to happen. The error and near misses occur when the holes in many layers momentarily line up and permit the passing of an error through different steps of the process. It doesn't matter how skilled a person is, we're not perfect, and everyone is capable of making mistakes. So instead of expecting endlessly perfect human performances, the conditions under which human work is what must be changed in order to minimize or hopefully avoid all errors. Next slide, please. Thank you. So if you look at it from a global scale, data from the World Health Organization shows that 1 in 4 patients is harmed by the care they receive in primary and ambulatory care settings. Approximately 6% of hospitalized patients experience an adverse drug event during their hospital stay. It is estimated that in England alone, there are around 237 million medication errors annually. Now, in the United States of America, medication errors cause at least 1 death every day, and it injures approximately 1.3 million people. And it comes at a cost, which is estimated around 42 billion US dollars. And that's almost equivalent to 1% of the total global health expenditure. Next slide. So what about in Taiwan? If we were to specifically look at the reports from hospitals, medication errors account for around 40% among all. Within those errors, 71.4% were caught as near misses and 2 deaths out of a sample of more than 27,000. And this is through the Taiwan Patient Safety Reporting System that was actually initiated in 2005. We have more than 12,000 participating organizations, including hospitals, long-term care facilities. And over the time, we've documented more than 714,000 cases. Next slide. As you can see, the most common reason that medication errors occur in hospitals is actually when the physician enters a prescription. And that might have the incorrect dose, be a duplicate order entry, or simply have the incorrect amount of drug. Next slide. Next slide, please. Thank you. With all that information in mind, how do we approach this problem? So it really comes down to three main ways. First is changing or upgrading a system used by the organization. Second, face-to-face education with the patient, him or herself. And last but not least, through the act of medication reconciliation. Next slide. So CPOE is short for computerized physician order entry. It's a process of electronic entry of medical practitioner instructions for the treatment of patients, particularly hospitalized patients, under his or her care. Now, the entered orders are communicated over a computer network to the medical staff, or the pharmacy department in this case, who are then responsible for fulfilling these orders. Now, think back to the data that was shown by Taiwan's Ministry of Health and Welfare. We know that majority of medication errors derive from the placement of incorrect entries. So the fastest way to prevent these problems is to set limitations, and that could be by having a maximum dose. So for example, ticaplanin, you can only prescribe 2 grams per day. As we move to the middle of the screen, a limit on the frequency for levofloxacin, so you can't prescribe frequencies greater than once per day. At the bottom, to prevent duplicate orders being entered, the physician is only able to prescribe 1 carbapenem at a period of time. Next slide. So at the start of the year, we actually went through a huge system transition, and I can say for first that it definitely wasn't easy, and we're still trying to get used to the new gadgets and everything. But the bright side is throughout this entire process, our pharmacists were able to work closely with the IT team by providing evidence-based information, giving instant feedback, and that's to create a more efficient computerized healthcare system, and always having that mindset of ensuring the patient safety. Now, in this case, cefazoline is to be prescribed for neutropenic fever. The computer automatically collects and shows the most recent lab data, and that includes the patient's weight, renal function, etc. Then according to the indication, certain doses and frequencies are then suggested. Next slide. So here's a more kind of detailed step-by-step run through of what the physicians actually see when prescribing antibiotics through our new patient management system. So the first step, of course, is to type in the antibiotic you want, and you type in CEFA, and it automatically pops down, and then you click on it. Second step is to confirm the patient's weight. If it's empty, you're required to fill it out. Next slide. Third, of course, the reason of use, whether it's an empirical or targeted therapy. Fourth is the just typing in the frequency, and then the computer kind of fills in the rest when it comes to the route of administration or dose. But currently, when it comes to off-label use, the physician still has to type in the dose and frequency him or herself. Next slide. So for the antibiotic dosing regimen, this may seem extremely simple, but behind each suggested dose is an Excel sheet of information collected, provided, and checked by pharmacists. Next slide. Now, once the necessary information is filled out, there's still an option to go with a higher or lower dose within that certain renal function range. But of course, this is to be discussed, decided, and finalized by the healthcare team according to the patient's clinical status. In this case, the critically ill patient is going through a septic shock, so a higher dose of cefazoline 2 grams QD is more appropriate. Next slide. However, if the patient were on some form of dialysis, the physician would have to select that option as well, and then the medication's dose, of course, should also be further adjusted. Next slide. So once the order is confirmed, it can even be temporarily saved to be prescribed later on. And if, let's say, the antibiotic is considered a second line and should not be used empirically, consulting an infectious disease physician is requested. Next slide. Now this order is then confirmed by the nurse, and once again, during administration. So, and just like that, the prescribing process kind of comes to an end. But I think the take-home message here is that a pharmacist is not limited to promoting patient safety at an individual patient level, but an organizational and as well as in the policy development level. Next slide. So moving on to patient education, which is crucial. I'd like to share with you guys 2 real-life cases. The first patient is at an age of 90 years old, and she was still able to walk every day in the morning, live and cook for herself. She weighs around 50 kilograms and had a past medical history of end-stage renal function. failure, requiring hemodialysis 3 times per week. Other comorbidities included chronic heart failure. She had 2 bare metal stents placed earlier the same year, and dyslipidemia. Next slide. In June of 2020, her low density lipoprotein levels were at 185 milligrams per deciliter. Her chronic medication includes dual antiplatelet therapy, PPI, beta blocker, statin, and midodrine prior to dialysis. It was in August, after complaining of persistent shortness of breath, that the patient went under a myocardial perfusion scan exam, showing a total ischemia extent of 20%. Now, a few days later, she was then admitted for a scheduled recatheterization, and the surgery went extremely well. However, what I noticed was that despite statin use, her LDL levels did not show any improvement and was still greatly above our goal range, which is less than 70. Therefore, I went to her bedside and conducted a consultation, and that is when I found out the real reason behind these bad lipid profile numbers. Next slide. So what the patient does is, once she picks up her chronic medication, she throws each individual bag away, puts it in the drawer, and when she needs to take them, she only actually takes the pills that she's familiar with. So when I showed her an image of torvastatin, the outer package and pill, the patient obviously did not have any recollection and most likely did not take it. And that was the reasoning behind the elevated LDL levels. And after further discussion, you then realize the patient isn't really taking her hypertension medication as well, due to the fear of hypotension. And the patient seems to have stock of other medication at home when it comes to calcium acetate, which she tends to take occasionally. So all this information was brought down on her digital health record and passed on to the main physician, in which I was later informed that the patient and her family during clinic follow-ups was extremely thankful for the help, and the patient's lipid profile has since shown great improvement. Next slide. So moving on to our second patient, who's a little bit younger, at the age of 70, has a medical history of MG, diabetes, and dyslipidemia. She does not smoke or drink, but does take more than a few supplements. Next slide. So the patient has gone through a few hospitals in the past. When it comes to organizing the necessary data, it definitely took a while, but as we kind of discussed further on, you will realize how important it is to document data, not just for the patient, but other healthcare professionals, to give a real well-rounded assessment. And that data would also include imaging. Okay, next slide. So I've seen the patient had a persistently high triglyceride level despite medicine use, but through a bedside visit, that is when you realize that the patient had misconceptions of all drugs being harmful and had previous bad experience, including dizziness from bisoprolol and GI upset from aspirin. And of course, this was all documented and passed on to the main physician. But the main point here is, even with the right medication, if the patient doesn't take it really won't help. And it eventually leads to a huge cost for the medical system. Next slide. So by taking the time to adequately interview these patients and by explaining the rationale behind the recommendations and choices, I do believe we as pharmacists can prevent future medication errors, gain greater patient trust, and further ensure treatment efficacy and patient safety. Next slide. And so far, we have a team of 6 people. We've been able to conduct more than 50 clinical pharmacist-led consultations per month. Next slide. Now, after preventing possible medication errors through the help of technology and face-to-face education to reinforce medication adherence, medication reconciliation comes in place. So here, as you can see, there is you go onto the patient's medical record, and there's an option of clicking forms. So click. There should be an animation. Yes. One more click. Okay, and it brings you here where there's multiple forms you can fill out. And in this case, it's for medication reconciliation. Next slide. So here you have your patient's basic information, name, date of birth. And the best part is, once you open this sheet, majority of the blank parts are already filled out by the system, drawing from the patient's national health insurance card, which stores records of medication usage and past examinations, and of course, our hospital own medical record system. So here the pharmacist is able to kind of click on, you choose the form of intervention you would like to, where you notice maybe there's an incorrect dose, incorrect frequency, and then write down a more detailed assessment. One more click. Okay, so by interviewing the patient or family members, we then select whether the patient has good or poor compliance in this case, also certain habits when it comes to medication use. Once documented and saved, this information can be accessed anytime through electronic interfaces when needed. Next slide. So as you can see, within a year, we've increased our medication reconciliation services. Next slide. And as previously mentioned, I highly advise all to look into the toolkits for pharmacists when it comes to medicines reconciliation, medicine use review that Matthew will kind of draw upon, and all published by FIP. Next slide. So by building a system of defense, we as pharmacists can and have safeguarded the patient safety from the beginning till end. And as we come to my final slide, the clinical, humanistic, economic burden of medication errors is truly immense at the individual, organizational, national, and global levels. But with a well-structured, patient-centered assessment, are we then able to identify, resolve, and prevent future medication errors from happening? And as a result, ensure optimal medication therapy, reduce drug adverse events, and improve clinical outcomes. So all in all, MUR is a valuable service to promote patient safety by addressing these medication errors and reducing medication-related harm, especially when led by pharmacists. Thank you.
Thank you very much, Naiva May, for your excellent presentation. So, and now please, again, there's some questions now coming, and that to our post to chat, and this question and answers port. And I think there's some very important issues coming out about like this different kind of concepts and definitions that we use for medication reviews. And we are now talking about collaborative medication use and medication reviews where pharmacists are active partners in reviewing medications. And it's great that we are getting more comments. And now we can move on to the last part of our presentations before the discussion part. And now we will hear about the FIP toolkit on medicines use review that was recently published, as we were mentioning previously. And it is my honor to introduce the speaker, who is also the person who was establishing the toolkit, Dr. Matthew Hung, who is the clinical staff pharmacist at the St. Mary's Hospital, Canada. And he was like this toolkit co-author, and he has PharmD and residency training in advanced pharmacotherapy, and he works as a clinical staff pharmacist at an urban community teaching hospital in Montreal, Canada. And his main area of practice is in critical care. And he currently consults for FIP in practice development. And it is always very important to involve people who have hand-on touch to these issues to work with us. But if we are academics, and then we need policy people, but then we need to very much listen to these people who really are working with patients. So now we are looking forward to your presentation and introduction to the toolkit, Dr. Matthew Hung. The floor is yours.
All right, thank you very much. Thank you for the introduction. As discussed, I'll be talking about the toolkit. If you can go to the next slide, please. And before diving into the toolkit, I think I'll just echo the comments and insight that my previous colleagues mentioned, and saying that The global burden of medication errors is huge. They have potential to cause significant harm to our patients and to place a huge burden on our health systems as well, which is why that our role as experts in medicines, as core members of the healthcare team are super important in trying to tackle this public health issue. So we saw these statistics earlier. So in the United States, at least 1 death per day is deemed to have been caused by medication errors. And worldwide, the cost of medication errors is estimated at 42 billion US dollars. Next slide, please. So patient safety, is a priority for all. In 2007, WHO launched their High Fives project to address really 5 different major patient safety challenges, and notably medication safety was one of them. And then 10 years later, they launched their 3rd global patient safety challenge that they really wanted to target medication-related harm and named their challenge Medication Without Harm. And their goal was to reduce a medication-related harm by 50% within 5 years in 3 areas of commitment. So that's high-risk situations, so looking at medications with the greatest potential for harm, in patients with polypharmacy, and at transitions of care. We can go to the next slide, please. So as we previously mentioned, FIP has been sort of continuing to represent and advocate for pharmacist-led contributions in tackling medication-related harm and in ensuring patient safety. So the FIP, Working Group on Patient Safety, published a reference document last year to sort of highlight the different areas in which pharmacists could intervene in patient safety. They provided case country examples and really looked at different possible interventions at different levels. So patient level, organization level, and systemic levels. And this adds on to FIP's continued work to advocate for pharmacists on this issue by creating documents, publishing a statement of policies, and collaborating with WHO and other stakeholders as well. We can go to the next slide, please. So in light of this, FIP developed a toolkit to focus on the service of medicines use review. So this was developed and completed by the help of volunteer and members from the practice development team here at FIP, and it was released in December 2020. And in this document, we try to define the concept of medicines use review. We provide implementation tools, and we try to showcase evidence and some country examples as some of practices that are happening around the world. And a second toolkit was actually developed earlier this year in February on medicines reconciliation as another additional service that pharmacists can offer to ensure patient safety. And we actually will have an upcoming talk on this second toolkit that you're all invited to attend as well. So if we go on to the next slide, so we looked at different definitions and tried to develop our own definition of medicines use review. So our definition here is a structured, patient-centered assessment of the effectiveness and safety of a patient's medication therapy and adherence to such therapy. And I'd like to touch on a few concepts that come out of this definition. First is sort of the structured aspect of this service, in that it's a service that should be established according to a certain framework. There should be policies and procedures in place so that that service is done as effectively and as optimally as possible. It's also an assessment that's going to be patient-centered, so really putting the patient at the focus of our assessment to make sure that our analysis and that the recommendations will yield optimal outcomes for our patient, and likely afterwards they will trickle down to different outcomes that could also affect our health systems and our establishments as well. And when looking at different aspects of the medication therapy that we will be assessing, we'll be looking at different components, such as the effectiveness, the safety, and the adherence of their medication therapy. It's important to highlight that a medicines use review is really a component of a total bundle of services that we as pharmacists can offer to help ensure patient safety. So other things like medication reconciliation or patient education, those are important factors that all in all can help to improve patient outcomes and ensure patient safety. So if we go to the next slide, so in this toolkit, we highlight different practices that are done around the world. So things, services that have different names according to different parts of the world. So things like domiciliary medication management, meds check, drug utilization review program, high performance medicines management, and medication therapy management. So things are being done around the world. And when looking trying to be inspired or trying to look at different practices around the world by looking up their specific names. I think that can help us gather more specific information and hopefully learn from different things that are going on from our colleagues in different areas. So for sure, you can feel free to share your practices, and that way we can progress as sort of a global community to learn more about one another and to move forward with the service. So on the next slide, when advocating for medicines use review, of course, I think all of us are sort of convinced of the benefits associated with medicines use review, but advocating it to higher level individuals, to stakeholders, to health systems, to establishments, sometimes we need evidence to back ourselves up. And evidence on medicines use review isn't necessarily, the body isn't necessarily the most thorough or the most widespread in terms of literature, which could be due to possible confounders or differences in definitions and outcomes. But there have been some data that has been published, and some of it was already discussed previously in this webinar. But in Spain, they actually did sort of a nationwide research. And by looking at pharmacist-led medicines use review in the community setting, they were able to demonstrate that it was associated with a 50% reduction in the number of patients visiting emergency departments, as well as a reduction in the number of patients reported to have been hospitalized. And then medicines use review has also been associated with other clinical benefits, such as a decreased polypharmacy, a reduced preventable adverse effects, improved disease control, and improved medication adherence as well. And not only looking at the clinical side of it, but also looking at sort of the economic benefits that we could gain with medicines use review. So this study here sort of demonstrated that a comprehensive medication review, this was performed as sort of a bundle of different interventions done by pharmacists on the ward, could lead to a reduction of $230 of healthcare associated costs per patient. So there definitely is some numbers, some tangible data that we could use to reinforce the service, and especially its impacts towards our patients and our systems. But there's definitely more that can be done to really contribute to the growing body of literature about medicines use review. So if we go on to the next slide, please. So in our toolkit, we first try to describe different conditions that are ideal or that necessary to implement effective medicines use review. So the first component is the data and access to information. So that's having access to patient information, knowing things about their history, having access to their chart, or maybe information about recent hospital admissions, just to sort of have all the information at hand to be able to adequately perform our analysis and review the use of medicines of our patients. And that can be accessed through different means. It could be through a nationwide database. It could be through paper charts. It could be through patient interviews as well. So really a wide array of different means. And then we also discussed things like resources and logistics. So for example, pharmacists working in the community setting also have to take on different responsibilities. They have to oversee compounding, they have to be dispensing, they have to be counseling patients and providing education. So really having a dedicated time to perform medicines use review is something that should be considered so that so that the service is provided as optimally as possible. Pharmacists should also be equipped with the necessary equipment and physical spaces in order to access information, in order to reach patients, in order to discuss patients in total confidentiality, in order to perform the review. And there should also be a remuneration scheme that sort of exists to sort of compensate pharmacists for their service. It, on one hand, sort of reflects the time and the effort that they put into delivering the service and to analyzing patient files and to making suggestions, but it also recognizes the expertise that we have in medicines, and as well as the relationship of trust that we have with our patients as well. And finally, to implement effective medicines review, definitely there needs to be a collaborative setting. So there should be methods in place to adequately communicate and document the results of our analysis, and discussions with prescribers and other healthcare practitioners are definitely beneficial and are necessary in order to implement the changes that we want to make to medication management, as well as communicating to the patient themselves regarding the changes that are brought on to their medication therapy. We also included a setting on low resource settings. So that could be smaller scale pharmacies where their resources are not necessarily available as promptly or as extensively, but having low resources doesn't necessarily represent a barrier to implementing effective medicines use review. Even in these smaller scale pharmacies, we believe that different conditions can be met in order to implement this service, and that's something that we highlight and discuss in our toolkit. So if we go to the next slide, we discuss a step-by-step process for medicines use review in our toolkit. And I sort of like to think of it as, a recipe for banana cake. Some people will have, they'll add on nuts, or some people add on cinnamon, but our recipe for medicines use review is really not a one size fits all. It's more of a starting point for members, different associations to implement a medicines use review according to their local practice and according to their specific setting. So we'll go with the different steps of what we've laid out in our toolkit. So the first one is collecting data on the patient and on the clinical data of the patient. So that could be things like the past medical history, past surgical history, the patient's age and weight, their history of allergies and intolerances, how's their renal impairment, how's their hepatic impairment. So collecting that data is important, as it will sort of give us a starting point to our analysis. Then we'll go on, obviously, to the review of medicines, which I'll describe on the next slide. Afterwards, we'll look at the patient comprehension, so to see, if their level of health literacy, to see how reliable they are as a historian, to see if they're aware and capable of monitoring some of their diseases using different tools and different equipment. Afterwards, we'll look at how they manage their medicines and their adherence. So to review if ever a pill box will be beneficial for them, if ever they've developed techniques or tricks to help them remember to take their medications as they are prescribed. Those really encompass the different types of reviews that can be done when doing our analysis. Afterwards, the follow-up can be organized if ever there's lacking, lab results that we want to suggest, if ever there's, different pieces of information that are missing from our analysis that we need to collect, that's when we can organize it. And finally, we'll communicate our analysis to the rest of the team and to the patient themselves. So that can be documenting the information in a chart or in an electronic health record, and then discussing with prescribers or other healthcare practitioners regarding our suggestions, and finally referring the patient to another healthcare professional or to their physician if there are things that need to be reassessed from another point of view. So if we go on to the next slide, where it's specifically on medicines, on information for medicines. So these are different data that should be collected for each of the medication that the patient is on. So the first one is their indication. So to ensure that the medication is being prescribed for a reason that's still relevant according to the patient's current clinical situation. There's the dose. That's always something to assess based on the indication, based on the patient's renal function and hepatic function as well. There's also important to look out for things like adverse effects to see if a medication could be contributing to any of the patient's signs and symptoms, or if there's a possible harm that could be prevented or managed by adjusting medicines. Afterwards, there's the component of monitoring. So if there's any specific lab values we need to do, any therapeutic drug monitoring that needs to be done as well, followed by interactions. So it could be drug-drug interactions, drug-food, drug-disease, drug-natural health product interactions. So different things where we can put our expertise really to play in order to detect these interactions and manage them. And then finally, there's the simplification of a dosing regimen or route of administration. So is there any way that we can decrease the pill burden that's associated with the patient's medication therapy? And then finally, place in therapy. So going back to see, is the treatment or the therapy that the patient is on, does it correspond to guidelines or to practices in literature? And is there any way to optimize that? So these are really just the different types of information that are available to review for each of the medication that the patient is on. So on the next slide, you'll see some of the template forms that we've developed in our toolkit. So these really sort of look at the first step in our step-by-step process of medicines use review. So the component of personal information, as well as any clinical data and investigations that can be done. And the template forms that we've developed in the toolkit really develop them so that they can either be used directly in your fields of work, or to be used as sort of a starting point as well and adapted to your local practices. So these are template forms for the patient themselves. And if we go on to the next slide, we'll see the template form for each of the medication. So we separated so each line would represent a medication, and each column would represent the different information available to help us with our assessment. And the last column would be a column for analysis to demonstrate, if there are any possible adverse effects we need to monitor, any actions to take, or any interactions that may be possible. So if we go on the next slide, I can just show you a little bit of an example. So if you look at the first line and we look at pantoprazole, we can set ourselves, let's say that we're a hospital pharmacist on a ward in internal medicine. We've completed the medicines reconciliation with the patient and with the list from the retail pharmacy. And now we're looking at the medications that the patient was prescribed in hospital to sort of assess whether or not each of them are adequate for the patient in terms of safety and effectiveness. And of course, there's adherence as well that could come into play. So the first medication is the pantoprazole, which is a coated tablet prescribed at 40 milligrams daily, taken by the mouth. And the indication is unknown for this medication in this example. So, if in this case, we would be discussing with the patient, and the patient would say they'd be taking it since 2018, and the indication would be unknown. So that sort of helps us in our analysis in the sense that it gives us the opportunity to look further for more information to assess whether it's adequate or not. Does the patient have a history of dyspepsia? Have they had a history of gastrointestinal bleeding? Are they on any medication that could increase that risk? So by having collected that information and having an indication that's really unknown, you can help to see if it's something that should be continued or something that we can actually deprescribe. If we go on to the next medication, so amlodipine, it's a 5 milligram tablet taken once a day by the mouth. It's indicated for hypertension, and the average blood pressure seems to be within normal limits. We could also ask the patient if they have any adverse effects, and if they're tolerating it well, we can see that it's sort of effective and safe for the patient. And they say that they take it regularly, so the patient would be adherent to it as well. So no major issues for that. We could continue monitoring the blood pressure and the risk of any adverse effects. For the third medication, we'd take a look at metformin. So it's a 500 milligram tablet taken twice a day by the mouth. There's an indication for type 2 diabetes. And if we were the pharmacist, we'd be looking at different lab values, and we would notice that the glycated hemoglobin was 8% from February 2021, so a bit above normal limits. So that could clue us in as to why his diabetes control is not necessarily as optimal as it could be. So we could look at patient's adherence to the medication at home. We could check whether the patient has any adverse effects to the medication. And if ever, things seem to be going well, then there's opportunity to optimize the management. So should the dose be increased? Should we add different lines of therapy to the diabetes management? Should we reinforce counseling regarding nutrition and regarding physical activity? These are different components that can be taken as well. And finally, the last medication in our example is ibuprofen. So it's a gel capsule, 400 milligrams, taken daily by the mouth, used for chronic back pain. So in our analysis, we think that ibuprofen is something that could increase blood pressure, is not necessarily something that should be taking, chronically long-term. So that's a discussion that we can have with the patient to make sure they're aware of the risks when taking anti-inflammatories in patients who are known hypertensive, as well as looking at different alternatives in order to manage the patient's pain. So really, this template form is something that can be used to assess each of the medications that the patient's taking based on the different information that's provided, and to sort of make our suggestions and optimize their medication therapy as much as possible. So for my final slide on the toolkit, so really our objective here was to develop a toolkit that serves as a framework for establishing medicines use review. So we included implementation tools that can be used either directly or that can be really adapted according to different practices. And there are different examples available out there as well. So to pick know the things that you believe are best from each example is something that can help to create the best possible tools for your practice. And we also attempted to describe different evidence and research efforts that have been done on medicines use review to sort of help advocating for this service within your local practices. And really, it's important not to understate the potential that we have as pharmacists to contribute to patient safety. And one of those methods in which we can really take on a leading role is medicines use review. Thank you very much.
Thank you very much, Matthew, for introducing this toolkit for medicines use reviews. And now it is time for discussions, and I'm very happy to see that there's more questions coming to questions and answers board, and also something on chat. And would you like now to? I need to now ask advice from our team leader. How we could, is it, if you want to comment from the audience, I think it would be nice to involve people who are, there's more than 200 participants here, so that you can also comment. I take, or there's questions, but if you want to make any comments, is there anyone who would like to comment? And it's great to see that there's people from all parts of the world. And there's questions about how to get started, for example, and about the policy making, how we can get also this started in, from policy making perspective, but also practical perspective. If there's anyone who would like to share experiences of the best practices and how they got started with medicines use reviews in their own practice or in their home country. Maybe Naiwa May, would you like to share experiences from your own country? How did you get started with all this work in your hospital?
Of course, I actually do see a question directed at me within the Q&A box, and it says, do automatic stop orders have an important role in reducing medication harm, especially antibiotics? How is it implemented in your country? So to answer that question, my answer would be most definitely, because even with these defense layers in place, medication errors can still occur. And when it comes to antibiotics, I think it's extremely important to keep in mind that the goal is to ensure that antimicrobials are continuing no longer than necessary. So eventually it's going to result in antibiotic resistance, which is the last thing we want to happen. But with automatic stop orders in place, it encourages the reassessment of the duration of therapy based on the patient's response to treatment, and prescriber review of the latest laboratory microbiology and diagnostic imaging results after this specified length of time. It might be differently implemented throughout Taiwan, but I can speak for how we kind of conduct this within our organization. So every antibiotic order is only effective for 7 days, and after that, the order has to be renewed for use. But there are still times, where antibiotics are used greater than 14 days. And what happens is we have a certain pharmacist monitoring this. And once the data is collected, it is passed on to us. And as clinical pharmacists on a daily basis, we then, according to each ward that we're in charge of, we call the resident or maybe the nurse practitioner in this case, and to kind of discuss on the reason of this prolonged use, and possibly suggesting them to de-escalate into maybe oral medication or even discontinuing it if there really is no indication for the use. And last but not least, if they insist on continuing using this antibiotic, maybe getting a second opinion and consulting the infectious disease specialist. Thank you.
Thank you very much. And also, Matthew, would you like to comment how you got started and how you are progressing with these services and practices in your home country and also in your own hospital?
Yes, definitely. So thank you for the question. So, you know, medicines use review and things like medicines reconciliation are part of our curriculum. So things that we see and that are involved in during our rotations as a pharmacy student and as a resident. So really they're a core of our practice that we do on a daily basis, especially at the hospital, but also in the community setting. So I think that's where I sort of embarked on the journey to sort of look into the evidence, the opportunities that are out there. And it's definitely, like we've mentioned, like it's the common theme within this topic is that it's definitely an area in which we can contribute as pharmacists. So by integrating into curriculum or things like that can maybe help reinforce the implementation and the facility and the development of the competence from the beginnings of our academic career.
Yeah, that is very important that there will be a generation of pharmacists who are really prepared for having this role as the core in the professional activities. And maybe I can ask the same from Filipa, as you have been working at PCNE and globally, so that what you could see, how to get started, what are your recommendations?
Yes. Well, yes, I try to answer not only that question, but also some questions that have been included in the chat and comment on what has been answered by my panel colleagues. So I think one important aspect is the inclusion of medication reconciliation as part of medicine's use review, which in my opinion, it's not necessarily done. Medication reconciliation is part of medication review and it should be a step a priori, but it's not always done in medicine's use review, which is a different service. And I think this is part of the confusion and also, so, you know, Matthew was very good in presenting case studies, but I'll just briefly mention one that's very, very simple. You get a 70-year-old patient coming into the pharmacy, in the community pharmacy, and he's been prescribed with salbutamol, which he cannot use because he has manual dexterity. And so he asks the pharmacy for some help. And the pharmacist will provide him with a chamber. So that's excellent. That will solve the issue of handling the medication. It will likely improve medication adherence, but will it lead to better outcomes? No, I don't think it will, because as we know, the guidelines have been reviewed and this patient should simply not be prescribed with salbutamol. So that would be identified if we had medicine's use review as part of a more overarching service. So coming to the question of my country, yes. So we have in the law actually different types of services that have been recognized since 2007 and have recently been updated in 2018. In the initial pack of services, we had pharmaceutical care, which is a broad umbrella and can encompass various things. In the current legislation, we have two different services. One is focusing on adherence. We don't even call it anything, we just call it a service meant to improve medication adherence. And then it will be up to the pharmacists to know which type of intervention will be more appropriate. Sometimes it can be something very technical like the use of pillboxes, but it could be something more related to motivational interviewing or something like that. But then we have another type of service, which is medication review. So currently, and what I have shown you in the slide is the broader umbrella of medication review. So what we have done is to develop some recommendations so that pharmacists can know how to start. So these recommendations have various aspects mentioned, like which, and actually Matthew also referred to that in his presentation. So the target groups, what's the first step? Do you need to collect informed consent? All of that. What are the information sources? But as Marja also alluded to, that does not necessarily imply that the pharmacists will be competent to deliver the service. And that's why I think we need greater alignment with academia. So currently the pharmacy curricula is quite diverse in faculties. So in some of them, we have this topic as part of the undergraduate curricula more or less developed or even absent. And that is why the Pharmaceutical Society then builds on the postgraduate accreditation by stating that we do not have compulsory accreditation for the service, but we do have recommendations. So saying you should be doing this and that course to become responsible and accountable for the delivery of a high quality service.
Thank you, Filipa. And then coming back to these questions and answers that we have received, or questions to answer, there's also comments by Professor Nicole Brandt from the University of Maryland. And I know she has done globally a lot of work on geriatric pharmacotherapy and geriatric care. And would you like to make a comment yourself about your concern, how we can move on? What will be the next steps from here? Because now we have an excellent toolkit. So how we can make a plan for the implementation? But if you, Professor Brandt, are there still, would you like to comment on this?
Yeah, can I start now, Marja? We do it reverse because I speak too much.
You can start, yes.
Yeah, so I think the way the question is phrased, I actually think it's more in the light of the pandemic, right? Because we have changed in so many countries the scope of practice and even the legislation as a response to lockdown measures. So we do have the toolkit, but I think that the toolkit is a starting point. It will then need to be adapted to the national countries. But more importantly, I think in the national context, it will be relevant to look at the legislative changes that have just recently occurred. So in some countries, pharmacists were not able to deliver medicines at home, for example, and now they are able to. In others, they were not able to deliver hospital-only medicines, and now they are able to do this through the community pharmacy. However, these legislative changes just focus on the pure logistics side of medicines, so delivery. And the legislation does not mention what we have to do with the medication being delivered. So it will be important to ensure at the national level that the responsible associations for pharmacists provide the additional requirements for the delivery. Otherwise, we risk becoming post offices, and that's not really what we want. So the pandemics is a very good opportunity to ensure that the pharmacists can provide either through telephone, through the internet, whatever modes of remote technology, but provide the necessary advice on to ensure the responsible use of medicines.
Okay, thank you. And then there's some questions about the concepts. So what is, for example, what is the difference between medication reconciliation and medicines use review? I don't know if it's Matthew who could answer this, because it's very important that we have a good understanding of the concepts, what we are talking about, and what, because if we don't know ourselves what we are expected to do or what we want to do, I think it's maybe not impossible to proceed.
For sure. So thank you very much for your questions. So there is definitely some sort of, we need to distinguish both concepts, I think. And there are different terms that are used by different associations abroad. But in the way that we view it, and that's sort of why we've developed two separate toolkits, actually one for medicines use review and the second one for medicines reconciliation, is really to differentiate both of them. So medicines use review, in terms of how we look at it, is sort of an analysis of the patient's pharmacotherapy to assess whether or not the medications that the patient is on are really adequate according to their clinical situation, according to their level of health literacy and all that. Whereas the medicines reconciliation is going to be, usually done at a transition of care to compare medications. For example, for a hospital admission, you're going to be comparing medications that the patient was on at home, as well as the medications that the patient was on at the hospital, to sort of identify differences in the therapy, so what we call discrepancies, and to assess whether or not these discrepancies are intentional or not, and whether they're justified or not. So really they go hand in hand into sort of understanding the broader picture of what medications the patient is on, and to understanding and assessing whether or not these medications are adequate or not. So definitely, if you're interested in this topic and you'd like to learn more, our webinar next we'll be touching on the toolkit that we developed as part of the practice development team as well. And maybe that'll help differentiate both concepts and to see how both of them can be used together in the broader picture to review medicines and to help our patients. Thanks.
Okay, thank you very much. And there's also a question about the pharmacist's authority to make changes to medication, so that if we are conducting medicines use reviews, so that there should be also authority for us to make clinical decisions. So how do you see this? I think this is a quite critical issue in many countries, so that we can really work collaboratively and also have some right to make decisions on the patient's care. And I think that that's not a very easy barrier to overcome, I could say, for many of us. But would you comment on this?
I can comment. Yeah, this changes a lot according to of course, the legal status of the country. But coming from an international perspective, I think the most relevant is to ensure that all these toolkits and guidelines and recommendations and whatever documents that are made are shared with the medical associations above all. Because otherwise it's just going to happen what I mentioned in the evaluation for the UK MUR, where the service, one of the reasons why it didn't work was because the GPs did not accept it. And even in the UK, which is quite advanced in terms of having pharmacists, prescribers, not all pharmacists are prescribers, of course. So many of them are also obliged to follow the physician's recommendations. So you will need to have the physicians on your side. And so in the two examples I mentioned, one was the EDQM process and one was the Portuguese Pharmaceutical Society. And in both of these processes, we have several phases. So the first one is the review of the document by recognized experts in the area. And in this stage, I guess you can restrict yourself to pharmacists, but then you need another phase where you involve other stakeholders, definitely physicians, nurses, of course, I would say, patients, advocates also, and then you get to the stage of public consultation. And only after these three stages, then I believe you can launch these products.
Yeah, thank you. And then there's very much comments from the audience about also time limits, so how we can squeeze this kind of work in our workload. And then there was also some mentions about by Matthew about these template forms that we can use for documentation. And I don't know how much you have experiences of electronic templates, so that we could share this medication review documentation electronically with other healthcare providers who are involved in patient care. At least in Finland now, we are in the process of having this kind of integrated system that we can, even from community pharmacy, to make that documentation. But is it so? Is it May's turn now to comment?
Okay, Matthew, so you're going to direct this question at me. Okay, sorry, what was the question again?
It was about this documentation template. So if we conduct medicines use review or medication reconciliation, so how we can document and so that it will be, the documentation will be available for other healthcare providers involved in patients' care. So that otherwise, I think it will be a little like waste of time if it won't be available, the information to other providers.
Of
so
course,
do you
I
have
think
this kind of electronic system for that? Or
Yes. So the easiest way and how we used to do it was paper. So it's in paper form, and if the patient were to transfer from another hospital, let's say, we just have to ask them to kind of go back and collect their order information so we can kind of organize it all. But now it's more a digital, and so just like I mentioned within my presentation, once you click into their electronic health records, you can see all the notes, the notes and the medication reconciliation assessments, the interventions every single clinical pharmacist has done. So that is then stored within their national health insurance card, where majority of the Taiwanese people have, and that's extremely convenient for all of our healthcare professionals to do a very full-on assessment of the patient and to ensure that, there's no discrepancies when it comes to their medication of use.
Yeah, excellent. And Matthew, would you like also comment on this?
Yeah, definitely. So obviously, medicine review is something that's very important to be done with our patients, but oftentimes there are different things in our schedule that prevent us from doing it as effectively as possible. So having those talks with upper level management and people who are developing schedules and things like that to dedicate time to medicines use review would be perhaps a good way to start. It's all dependent on the resources that we have, on the workforce that we have in order to develop them. But having dedicated time would probably be the best way to ensure that this service is done, and utilizing different tools and having different structures and frameworks laid out so that it's done as optimally, as effectively as possible. So not necessarily more quickly, but more rapidly, but still with that same thoroughness and still with the same effectiveness. That way it can be done and fit in your schedule as much as possible.
Thank you. And then there's questions about resources and if there's any online courses or other ways that we could learn more about medication reviews, medicines use reviews, medication reconciliation. Do you have any good recommendations? And FIP, maybe from FIP part, you can also recommend if there's any resources available, but otherwise, how we can learn more of these skills.
Yep, so I'll jump in. So definitely in our toolkit, in our best practices section, you can see the different terms that are used for medicines use review. And Filipa touched on it as well. So you can look back on the webinar to see the different terms that are used. And by looking them up, I think you can see the different tools that are developed by associations to implement this type of service in their own country. Otherwise, in the literature, there's evidence available as well that you can look at. Yes, to see the benefits, but also to see whether there's different methods that are in place as well. The WHO for their Medication Without Harm Global Patient Safety Challenge also produced technical documents that you can consult as well that provides examples and examples of practices that you could use for your own local practices. Thank you.
Okay, thank you. And then there was also a question about the policy making, so that about the good examples of policy papers, or policy documents that are leading the way towards pharmacists' involvement in medicines use reviews. So do you know that kind of good examples, as you have been cooperating with countries and people, that could be good readings for those who want to promote this also nationally through the policy making?
I can add. I mean, I think the EDQM resolution on pharmaceutical care is a good and relevant, at least for Europe. I don't know if the participant asking that question is from Europe, but anyway, it could be a good starting point. Then the major issue is the language, I guess. So I could send other documents, but they are heavily depending on the language of the participants. I don't know where the person is from. But so I would start with the DQM first, probably. And then in that resolution, you will also find some references coming from individual countries, which you can then assess. And that could be a starting point.
There's also case studies in this FIP document on patient safety. At least it has plenty of case studies from different countries and how they have been proceeding with patient medication safety initiatives and the best practices. And then also from Finland, we have a rational pharmacotherapy action plan that was established 3 years ago. And I know it is available in English also. It's by the Ministry of Health. So maybe it's something I can also send if you want to share it with anyone, so that what are the long-term goals in our country in this respect. But thank you all, speakers and participants. It's been an excellent session and we have learned a lot, and I hope that there will be now that kind of messages to take home and continue with this important work towards patient medication safety and no harm to our medicine users and patients. And FIP is regularly organizing this kind of digital events, and please go to their website. There's the address, and find out what will be your next webinar to participate, and make a plan of participating, because this is a very good way of updating your professional knowledge and competency. And so there's my final slide. So thank you for attending, and I want to come back to this Swiss cheese model. It's something I learned 15 years ago, and still it is my favorite figure. And this is something we teach to our students. Every student needs to learn how to apply this into practice. What does it mean that if something goes wrong with the medication, for example, the physician prescribes wrong medicine, how we can then make this kind of systemic defenses so that it won't reach the patient. And I think it is the core in systems thinking. And if we learn that and learn it to apply in our professional practice, I'm sure that we will be very successful with patient medication safety, and also how our professionals are respected as part of healthcare team. So I really highly recommend that maybe tomorrow when you go back to your practice, you could find out how you can start applying this very, very useful tool. But thank you for all, and have a good day. And also thank you for FIP and the team who organized this event today.
Thank you.
Thank you very much.